So that's a study that we've done in collaboration with Heidelberg University, particularly Mark Rabe and Niels Weinhol, and will be presented by Marcela Cadura from my lab. And what we did together is assemble a very large series of whole genome sequencing, 421 patients, and perform a very complicated but comprehensive temporal analysis using a molecular time, which is a method that was developed at the Sanger Institute by my mentor Peter Campbell, and is basically a method that allows you to estimate when a certain alteration is acquired on time. So doing this, we report like a lot of data. It's a very dense presentation, but I guess for the clinicians and for the general audience, one of the key points are that when you have hyperdiploid and IGH translocations together, and we don't know which is the first, IGH is always the first. And hyperdiploid is very heterogeneous and often is acquired with other alteration, including 1q. So 1q can be as early as hyperdiploid. It's not just a late event. It's something that can be acquired late and early. 1q can even be acquired after transplant. So it's kind of like, it's not just selection, it's also acquisition, something that is completely new. And finally, I think the most striking results is that 1q in the context of multiple myeloma has, a clear and established prognostic role. If you have it, you go worse. And recent findings suggest that if you have two copies, extra copies of 1q, called 1q amp, amplification, you get even worse. So what we found is that it's not really the number of copies that matter, but when you get the 1q in the patient life history. So if you get the 1q very early on time, which could be 2-3 decades before the diagnosis, that's very bad. If you get 1q very late, that's almost doesn't matter. All the 1q amplification have the first gain acquired early. So the early 1q and the amplification are exactly the same clinical outcome. And we're talking about patients treated with very up-to-date and effective therapies.